Started. So, hello everyone. Welcome to our September Wellness Wednesday webinar. My name is Katie Powell. I'm a well-being consultant with Care First, and I'm so excited that you're here today with us. If you joined in August, you know that we focused on back-to-school wellness by refreshing safety protocols, exploring ways to stay energized, and prioritizing our mental health. This month, for September, we're focusing on prostate health and prevention by learning about risks, symptoms, and screenings, understanding proper treatment protocols, and finding ways to support and raise awareness for men's health. I think we're in for a real treat. I know we're in for a real treat with our guest presenter, Dr. Udwin. Dr. Udwin is the Provider Collaboration and Network Transformation Medical Director at Care First. He's an accomplished physician executive with over 25 years of experience leveraging advanced analytics and evolving electronic health record environments. He ensures broad-based physician alignment as payers, providers, and emerging enterprises reimagining the healthcare of tomorrow. Dr. Udwin, thank you so much for presenting, and I'm going to turn it over to you.
Oh, thank you for the warm introduction. I cannot imagine a better way to ring in September and pumpkins and fall than to talk about prostate health. So I am thrilled to be here with you today. And we'll make this very informal. I know it's hard when there's a group of people and there's just one presenter, but please put comments, questions into the chat. We'll make sure we have time at the end to hopefully at least address them, if not provide some clarity on whatever questions emerge from the conversation today. So if you could please advance to the next slide. As Katie said, we're going to talk a little bit about what in the world the prostate is now that it's Prostate Health Month, some risks, symptoms, and screenings that go along with the prostate, how to make sure you have a nice, healthy prostate and prevent any prostate problems in the future. And finally, if there are any issues with your prostate, where to go and how to treat it. And finally, other resources are going to be available to you for not just your prostate, but your overall well-being. So with that, we'll talk a little about what in the world the prostate is. And it's kind of a cool thing in preparing for this. Just a couple of things came to mind in thinking about the prostate. One, it does engender certain age. So there's sometimes some stigma associated with the prostate. Boy, that's an old age problem. And that really isn't necessarily the case. In fact, in thinking about this, I went ahead and did my real age again to reconcile any differences in how I feel with how my prostate may feel. So don't be afraid to check your real age as you move forward and check that against your calendar age. The word prostate just kind of couldn't have a medical discussion without going back to Greek and Greek literature. Comes from the word protector, guardian, and exactly what the prostate does. The prostate does sit in front of the bladder and comes from the Greek word prostates. So next time you think about prostate, think about prostates and think about your prostate being, or your friend's prostate being, the protector of the bladder and all that's around the bladder. So we can go to the next slide. We do have a poll question, and it'd be really, really, really fun to get thoughts, and you can either put them into the chat and Katie can talk about it, and I'll even try and throw my chat up there as well if I can walk and chew gum here, to think about the prostate. But when you think about it, you think about what is the biggest barrier for men when it comes to the prostate. And you know what? The answer might be different depending on your age too, right? So if you're old, you might think about it, boy, I don't want to go to the doctor and have to deal with another thing, or I'm worried because my friend had prostate issues in the past. If you're younger, it may be the stigma associated with it, or the impact it could have on sexual function. So it really depends on where you are in your own life cycle and how you view that particular question. There was an interesting study was done by Cleveland Clinic that found that about 70% of men would rather do household chores than go ahead and get their prostate checked. So there is some resistance about going to the doctor, about having your prostate checked, and also some fear about what that exam could engender and entail. So Just looking at our live study now, lack of awareness is important, and we'll talk about that as we think about why screening is not done. Fear of diagnosis, a little bit lower on the list of 24%, 25%. Stigma, embarrassment, we talked about it before, 38%. Cost or limited to access care, kind of good that that's not hitting the radar and reflects hopefully some access issues that aren't necessarily always in play, but certainly can be in play as we think about this. So very important. Bottom line looks like awareness is important, stigma, and then fear of diagnosis. We're going to address all three. All three are relevant as we think about the prostate and about prostate health. So with that, let's jump into some statistics around the prostate and how we think about the prostate. So it is an important thing to talk about, and there's a good reason why it's on our list of topics for the month of September to think about. It is the second most common cancer in men, right behind skin cancer, and the second most common cancer death or mortality for men, right behind lung cancer. So it is important. 1 in 8 men will be diagnosed with prostate cancer sometime in their lifetime. What's really kind of interesting about it, and it's is the demographic incidence curve we've seen. For a long time, there was a drop in prostate cancer screening and diagnoses until about 2014, at which time it started to increase again. I think there was some confusion on how to screen and who to screen and how and when should be screened. And that's essentially, as we'll talk about, it's been clarified, and we'll talk about a little about screening as we move forward. There's about 313,000 new cases diagnosed every year, and that's as of about 2025, where we are in this year, and looking back to 2024. The increase in incidence, the 3% increase we've seen since 2014 is due to a couple of different things. One, we do have some clarity on the type of screening that should be done. Our population is getting older, which means that there's more folks who can get it. I think access has been improving, which is a good thing, and I put think in there because we're going to talk a little bit about access in the future. Unfortunately, another reason why it's increases is lifestyle implications. There is a higher rate among obese patients, and their obesity rate has climbed in recent years, and smoking still is a major issue as well. So, and we'll talk about the genetic issues as well. So there are reasons why it continues to increase in incidence and why we'll need to talk about it further. Cancer is never a great thing to get, but if you're going to get a cancer as a man, prostate cancer is a good one to get. Very high survival rates. It's usually picked up early, even when it's picked up later. It's slower growing, and therefore it has a very high survival rate, well over 95% when if picked up early or picked up at a lower grade. We'll spend some time talking about that in the next couple of slides as well. So again, we can't have a discussion of medical condition without showing one of these diagrams. And here's a diagram of the prostate. I don't know if I can show you with if I can move this around without. I'd move right here. Here's the prostate right over here. I tried to circle it right there. It's in a unique position for plumbing, right? So if you could see, there's a tiny little tube that goes from the bladder down through the penis right here. And because that tube is so tiny, if there's any inflammation of this big old blob around that tube, which is the prostate, it can impinge on the flow of urine from the bladder. So the patient's going to know pretty quickly if there's something plugging that hole that goes from the bladder to the outside. They're going to feel it. So you're also going to feel the need to pee more frequently. You have difficulty urinating, even some pain with urinating. The prostate gland is intended to nourish and transport sperm. So it serves a good function, but because of the plumbing, I'm looking over here where it sits here, seminal fluid, where the fluid would go to help support sperm, goes right through the same area. So you can see that if there's any impingement, because the prostate gets bigger or is inflamed or is growing at an abnormal rate, it's going to impinge on these tubes, either going from the bladder or from the seminal vesicles outside. And so therefore it's picked up early. If there's any abnormality in size related to the prostate, the patient's going to feel it pretty quickly and is going to bring them to the doctor's office. So that's kind of, in a weird way, the good news behind why, if you're going to have an issue with a particular gland, prostate's a good one for it to be. So what are the common prostate conditions? And this next slide will speak to that. And I don't know if we can remove here my annotations. Those are going to bug me if you can remove. No worries. As we think about that, there's three broad areas, the issues that impact the prostate. One is inflammation of the prostate, which we commonly cause prostatitis. Another one is benign prostatic hyperplasia, which is commonly called BPH. So BPH has a tendency to basically be a benign enlargement of the prostate. And when that occurs, again, the patient's going to feel it very, very quickly. So in that circumstance, you have an opportunity to go ahead and address whatever issues going on with the prostate. As we think about it, the final category, there's prostate cancer. And again, that's going to be an overgrowth of cells. Putting this into context, prostatitis, because it's an inflammation of the prostate caused by either an acute or chronic bacterial inflammation, it can occur at almost any age. Yes, it does occur more commonly in older folks, but a younger patient can get prostatitis too, easily treated with a course of antibiotics. Sometimes a longer course of antibiotics is needed because of the nature of how antibiotic reaches the prostate gland, but generally is easily treated. BPH2, or benign prostatic hypertrophy, because it's just an enlargement and it's not cancerous, it's usually slow growing and doesn't really you're never going to die from, or very rarely going to have an impact related to BPH. And again, because of where it's located, impacting the ability to urinate, you're going to feel it pretty quickly. Commonly occurs in men over 50. About 50% of men will have some enlargement of the prostate gland. Again, that's not cancer. By age 80, about 90% of folks will have some sort of enlargement of the prostate gland. The final category, that of cancer, again, it's usually picked up. It's a diagnosis of older folks. When it's picked up at an early stage, and it's not likely to result in loss of life. There's an old adage, they say that you're more likely to die with prostate cancer than because of prostate cancer. So it's often a common incidental finding done at time of autopsy. A patient may have lived 100 years old, die of a stroke, and they find on autopsy, they had prostate cancer too. Could have been there for 5 years, could have been there for 20 years, but that was not going to be the cause of death for that particular patient. So as we move on, let's spend a little bit of time on the risks, symptoms, and screening, because they are important. And I really want this time that we're spending together, and I'm grateful you're spending this time over lunch, to be productive and to give you some actionable information you can take away either to your family and friends or for yourself as you go forward. So as we move to the next slide, I really want to make this pragmatic. So there are things that are in our control and things that are out of control that impact our risk for developing prostate cancer. Age, that's a no-brainer. We really can't do much about our age. Our age is what it is, although I would encourage you to do your real age if you haven't done it. It's kind of fun to see how older or younger you are than your calendar age. But as you get older, you do have a higher likelihood of developing prostate cancer, and therefore it's important to talk with your clinician about what appropriate screening is going to be important for you. Other risk factors are genetic. Close to 5 to 10% of all genetic mutations for prostate cancers are linked back to a genetic mutation. It's often commonly BRCA1 and BRCA2, and women will recognize this too because it increases your risk of breast and ovarian cancer as well. There are other genetic conditions that as well increase your risk of prostate cancer and may affect your clinician's suggestion on when you should go ahead and get screened. Finally, race and ethnicity do play a role as well. In fact, African-American men have about a 1.76 increased likelihood or times increased of diagnosis and a 2.5-fold increased likelihood of dying from prostate cancer compared to white men. So there is some genetic linkage related to, and it's not just access issues. Even if you match up for access, there's some genetic issues related to the higher rate in African-American men compared to Caucasian men that may at times increase the likelihood of screening. Now, some of it is related to access in terms of looking at mortality. Some of it's related to the fact that if it was higher before, if you have family members with prostate cancer, that increases your likelihood as well that you are at higher risk of prostate cancer. So these are the risk factors that one wants to think about that are really out of your control, but would weigh into a decision to pursue more aggressive screening. What about those risk factors that are in your control? Like before, we were talking about ones that are out of control. What are the risk factors in control? The one that pops to mind first is being overweight. There is a likelihood that if you are overweight, we'll get to testing too. What tests are available? Oh, good. Such a good question, Troy. We'll get to it. And I'm so glad you're paying attention and asking that question. We'll definitely get to screening, Troy. And if at the end we haven't addressed it, let me know and we'll come back to make sure we have addressed it. So obesity. Obesity is a modifiable risk factor. So it's something that as the weight comes down, the risk for prostate cancer goes down too. What's interesting about obesity is that it seems to increase the likelihood that if you get prostate cancer, it's going to be a more aggressive form of prostate cancer. In fact, because of that, there's about 21 to 20% likely increased risk of death from prostate cancer if you are severely overweight. Severe obesity, by definition, above 35 on the BMI has a much higher rate of death from prostate cancer as well, close to 34 or 35%. So a good ballpark number, if you're talking to friends or family about this, is that if you are obese, there's about a 5, if you think about the BMI as less 18 to 25 is normal BMI, that there's about a 5 bump number increase in your BMI risk associated with a 10% risk of dying from prostate cancer. So if your BMI is elevated from 25 to 30, there's a 10% increased risk of dying from prostate cancer. If your BMI is 30 and it goes to 35, again, about a 10% increased risk of dying from prostate cancer. I apologize I made that more complicated, but the bottom line takeaway is that if you're overweight, it increases your risk. Smoking as well. Smoking, debate about whether or not smoking increases the risk of incidence of prostate cancer. But if you do get prostate cancer, it's much more likely to be an aggressive form of prostate cancer. The good news about smoking is that if you stop smoking for 10 years, that risk associated with prostate cancer goes away completely. And that holds true for lung cancer too. So a lot of the risks related to smoking go away if you can get about 10 years from your last cigarette. Your risk pretty much drop down to normal. Nutrition, we'll spend some time talking about in the future of what types of things are important with nutrition. But right off the bat, high-fat diet, lack of fruits and veggies do increase the risk associated with being, frankly, overweight, but also increasing the risk of prostate cancer. So those are the things that are important to think about from modifiable. It's basically your weight and incident to the weight, nutrition, and smoking. There are certainly toxins that can be associated with it as well, but I think for the vast majority of the population, just think about those two. Well, that will go a long way toward reducing and increasing your prostate health, reducing your risk. So if we go to the next slide, what I'd be wondering, and Troy, I promise we'll get to the question on screening, is what are the symptoms? What do you need to think about? We talked earlier about where the prostate lives. It's so close to the plumbing related to the bladder. So the good news, again, if you have any impingement, any squeezing of that tube that goes from the bladder to the outside, it's going to result in that feeling of urgency, like you need to pee. They may have to pee more frequently. Maybe you have to pee 5 or 6 times a night, at least, depending on where it's impinging on the bladder and that space between the bladder. So you're going to have urinary symptoms that are going to be quickly felt. You may have some pelvic pain that goes along with it. You may also have some blood in the urine. Good news about blood in the urine, because this always comes up as well. Blood in the urine does not mean you have prostate cancer. The vast majority of the time when you have blood in the urine or blood in the semen, it is not cancer. So I don't want you to be freaked out that there's blood in the urine. It's got to be cancer. Not the case at all. But if you do have blood in the urine or blood in the semen, it's important to get it checked out. Again, almost all the time, it's easily treated, but you want to make sure that you're not that one in whatever crazy number that has something really serious going on. So you want to make sure you get that checked out. With more advanced forms of prostate cancer, you can have other issues that go along with the legs, the feet, hips, spine, other parts of the body. You can have some erectile dysfunction as well, depending on the impact. And again, in more later stages of prostate cancer, weight loss and fatigue can play a role as well in the symptomatology that you notice. So again, anything that feels out of the ordinary with the plumbing or with your normal life, you want to get it checked out. So this is now going back in that checkout. We'll talk a little about what that checkout means, but it'll also feed into how we think about screening. So when we think about screening, this is what caused some confusion prior to 2014 of who should be screened, how should they be screened, when should they be screened. It even came up in the presidential election on when and how to get a PSA done and what age group is appropriate for a prostate surface antigen test. So let's think about it. When and how should you be screened? The prostate cancer screening is usually done through a PSA, a prostate surface antigen test. And what that does is a blood test that's done. What caused some confusion is should everybody have it done, and when is the appropriate group, and how often should I get screened for? The obvious example, if you're 100 years old, does it make sense to have a PSA or a prostate surface antigen test? Probably not, because what do you do with that information? Same holds true if you're 10. Obviously not. You're not going to have it done then. So what's that sweet spot to go ahead and have a PSA done, and what do you do with that information? The current guidelines are to go ahead and be counseled. This is again for an average risk man to be counseled between 55 and 69 to speak to your clinician about whether or not it makes sense for you. The reason they put that caveat in there is, what do you do with that information? Most of the time, if you're 55 and you have an elevated PSA, it's not going to be cancer. And the invasive testing you might have to undergo to prove that's not cancer aren't justified, because you're way more likely to have a complication from that test than you are to likely have prostate cancer at all. Above 70, it gets a little more tricky. And again, you want to go ahead and talk to your clinician about it. What's also a little bit tricky is we talked earlier about certain cohorts have a higher risk of prostate cancer, one being African American men. So again, it's important to talk to your clinician about whether or not it makes sense. Who else in the family had it? Are there any other risk factors that go along with prostate cancer? Or you go ahead and jump into a PSA test between 40 and 45. You could see there's ranges there, even on the high risk men between 40 and 45, because there isn't necessarily a consensus in the literature and in the guidelines by a specialty organization of whether or not it makes sense to have a PSA and in what age group to do it. So that's why some of this information is hedged with ranges 40 to 45, 55 to 69. I think the takeaway is, before you just run out and go have a PSA done, important to talk to your doctor about it, because what you want to weigh is the risks from a false positive, the test that says you may have prostate cancer, and the testing that may ensue, and biopsies that may ensue, and even complications from biopsies that may ensue, versus your overall risk of even having prostate cancer. So that's where that tension exists. So important, don't go ahead and just have a PSA done, talk to your clinician about it. I saw a question is in there about the chat. So if we go to the next slide, it speaks to the incidence of PSA, but also then speak to examinations that we do. So I want to take a second there and it's a really important knowledge test question here. What percent of men have had a PSA test between 55 and 69? And you could see, based on the way I phrased that prior slide, I don't want it to be 100%, because it's 100%, then it means we're going out and doing universal screening on everybody. And we just got done saying that it may not make sense for everybody to have a PSA. In fact, it may make more sense not to have a PSA done in that context, because of the ensuing problems that may result from it. So you can see here on this test here, oh, such a good group. Yes, we nailed it. So you can see here about 38% was the right answer, which also tapped out our group here too. So obviously a well-informed group on this audience here, and speaks to the fact that the messages are getting out, that not everybody should be screened in that 55 age to 69 age cohort. And just as we suggested here, you want to go ahead. So great question. There's a question there about the false positives, which I could not have planted that better. If we go to the next slide here. So if you go to the next slide here, this talks about the normal range for a PSA. And I promise we're going to come back to the physical exam question, because that's just as equally important. A normal PSA should be really under 4, but you can have a bump in the PSA between 4 and 10, which is kind of in that hedge group. The hedge group could just be hedged because you recently had sex, or you're a little bit older, you may have had some inflammation of your prostate gland. You may even so minimal, you may not have even noticed it was there. You may have been riding a bicycle a little bit. I know, right, Kevin? I'm with you. That's exactly what I would want to hear too. I'm 100% with you, Kevin. You were riding a bike. You just went on a Century ride. and your prostate had a lot of bumping up and down on the bicycle seat, that'll bump your borderline, your PSA as well. Certain urologic procedures can also increase it, and certain medications can even increase your PSA. So a small bump in your PSA does not necessarily mean anything bad. And even you see here, even a borderline PSA range, 1 in 4 shot, it's going to be prostate cancer. That means a 3 in 4 shot, it's not going to be prostate cancer. Even an extremely large PSA value, only a 1 in 2 shot is going to be prostate cancer. And I think those numbers are frankly a little bit high. Most of the time, if there's an elevated value, it's repeated, it comes back down, and there's nothing to see there. It goes away. So you're asking the right question. And the takeaway from this slide is that even if you have a slightly elevated PSA because you talked to your doctor and you thought, you know what, I'm worried, family history or whatever reasons, I really want to get a PSA done. Doctor calls you and says, oops, you know, it's a little bit elevated. Good news is you're not going to have prostate cancer. They'll probably just repeat the test and you go from there. Which brings us to the next slide, because I think the next slide is important almost as an anti-slide here. I put the slide on here and I kept the slide in here because, oh, God, thank you, Robert. Digital rectal exams, because I think for years, most folks thought, oh, digital rectal exam, that's how you screen for prostate cancer, and that just is going to suck. So as we think about it, the digital rectal exam really is not a screening tool. In fact, almost all organizations now that provide guidelines have removed it from their screening protocols. A couple reasons why. One, totally unfun test to go through, so nobody wants to go through it, and you're going to reduce your likelihood of doing screening. But even more importantly, by the time it's picked up on the digital rectal examination, it's gotten pretty big. So you can get a false sense of security that the digital rectal exam was normal, and therefore I'm loving life. I don't have to worry about it. So that really wouldn't be the case, because they give you a false sense of security. And frankly, the bottom line is when they've done large cohort studies and large meta-analyses, doing the digital examination did not change mortality rates for prostate cancer. Again, because by the time you're picking it up, it's pretty late. So not a good test to do for screening. If you had an elevated PSA, you had symptoms, the doctor may suggest you go ahead and have a digital rectal examination to see there isn't a mass there, but often that's not even the first line agent for imaging. Often you're going to go to jump to an MRI to make sure and really get a good look at the prostate. Again, because you're not going to necessarily pick up information that's less than a centimeter in size from that digital rectal examination that would you have gotten from a focused MRI. So an MRI often is a better way to assess the anatomy of the prostate gland rather than a rectal examination. So good news out there who are worried, oh, man, I've turned a certain age, I need to go ahead and have a prostate exam done. Not the case at all. So it's good news. It's not going to be the first line agent, probably not even a second line agent for digital for screening and management of the prostate exam. So I think most folks, that's a sign of relief. For the medications, I'm going to defer on that. We can get back to on the medications piece because I think there's so many different medications interactions. I don't want to jump the gun. So I think if you have a question about a medication, I'd rather you talk to your doctor on which medications they believe could be causing a problem for you. So as we move to the next stage, which would be prevention, we do want to spend a little bit of time on that because, again, we all want to live our best selves and including our best prostate self. So how do we go about it? So as we go about it, it begins with regular screenings. And regular screenings goes beyond just the PSA, right? I want you to think about, for most men, I don't want you to think that you're off the hook because, well, you know what? He convinced me. I don't want to go out and get a PSA. I'm 56. I don't think I want to have it. There's no family history, nothing to make me want to go ahead and have that test done. That doesn't mean you'd have other screenings done as well. So I put in here regular screenings, PSA being just one of other counseling exams you want to have done. You may need an exam of the prostate for other reasons, but I wouldn't necessarily assume that's going to be part of your screening for prostate cancer. We talked about balanced diet, right? We talked about modifiable risk factors for your prostate. Balanced diet is going to be one of them that's important. Exercise, right? Being active, getting 150 minutes of exercise a week, super important. Reducing smoking, reducing alcohol go a long way. Smoking particularly, if you can stop smoking, you get yourself 10 years between your last cigarette and where you are now, your risk goes away. For lung cancer, for prostate cancer, it all gets better. Alcohol, there's a volume, a dose response curve. So the more you can drop down the amount of alcohol you take, the better off in terms of lowering your risk of having a problem in the future. Let's spend a few minutes on nutrition because I think, again, this is a great way to talk about it. Prostate's a great segue into it. We talk about eating a healthy diet, but what does that really mean? I think if you go out and Google prostate health, which hopefully you will go ahead and do after this discussion here, certain things will pop up. Lycopenes will come up as an antioxidant. Selenium will come up as a way of improving your health as well. Vitamin D for immune modulation are all brought up as options to improve your overall health. Omega fatty acids will come up as a way as improving your overall prostate health. And even zinc comes up there. I don't know if there's enough information, enough evidence-based data to suggest that you should go off and jump on the lycopene, selenium, and vitamin D, omega-3, and zinc bandwagon, but it doesn't hurt to do your own research. And I think this is, again, I would say this to any patient out there or anyone who wants to take control of their own health, do your own research. If you think it makes sense for you to do lycopene or selenium, go for it. I just think I would do it with doing your own research and recognizing just there often isn't good information out there because it hasn't been well studied or the data is mixed. As long as you're not doing any harm and it's not going back to the earlier question on medications and PSA, as long as the medications and the alternative medicine you're taking does not interfere with other medications you may be taking, go for it. So that's why I would talk to your doctor about the medications, both for if you're taking vitamin D, if you're taking selenium, omega-3 fatty acids, and what other medications you may be on, because there can be drug interactions with some of these medications. Anesthesia always wants to know too, if you're having a procedure done, what alternative products are you taking? Because a lot of folks think if it's alternative medicine, not real medicine, quote unquote, and therefore I don't have to worry about it. It's not going to interact. That's often not the case. So go ahead, let your doctors know what you're talking about. Have a conversation, do your own research, and I'd say go for it. So what else can you do to improve your overall prostate health? Hopefully you're listening to this while taking a walk. And if that's the case, that's a great way to reduce stress, to feel better. You'll sleep better too. The more exercise you get, the better off you'll sleep at night. I was out of the habit, and frankly, I've gotten back into the habit in the last couple of months of taking my lunchtime, and here I'm breaking my own rule, of over lunch, spending a few minutes to do some box breathing or some mindfulness training. So it doesn't have to be a full course. You don't have to go somewhere to do it. You can spend a few minutes just doing some deep breaths, some box breathing, some walking around your desk or going outside on a beautiful day. That goes such a long way to reducing your stress. Regular sleep, it's hard to say go sleep more. No one sleeps more because they're told to sleep more, but just trying to do the best you can with sleep hygiene, finding out if you want to use a ring or a band or your watch to try and understand why you're not sleeping well at night, go for it. Maybe dietary related, maybe the caffeine, the lack of caffeine, who knows? But I do think it's worth spending a few minutes looking at your own routine, talking to others about what you can do to sleep better, and find support groups, right? Peer support groups. It's men have a tendency to be much more. I'm going to say that. I'm not going to say that. There is a tendency by some folks to be stoic, and the reason I took that away is because women often have that same tendency. So to not talk about it. So it's important to talk with peers, with friends, professionals about what they're doing, what's worked for them, what hasn't worked for them, and get support if you need support to improve your own prostate journey. What else can you do? So we spent a lot of time talking now about prevention. We talked about screening, but let's spend a few minutes talking about treatment as well. It's equally important. And I don't want you to think because you have a prostate problem there that all is said and lost, that you're going to lose sexual function, that you lose urinary function, you're going to be up all night, every night. That's not the case. The good news is almost all the conditions you have that affect your prostate are readily treatable, and most importantly, are not going to kill you. So this brings us to our next question, I believe. So true or false? All men diagnosed with prostate cancer need immediate surgery or radiation. So you know what? Anytime there's an all question, that's almost a gimme. We should have made it a little bit harder. We should have said the preponderance of to make it a little bit more tricky there. So as we think about it and we think about the prostate, there is a fear and a concern. And it comes back to the original question we asked, which was, well, I don't want to go to the doctor because I have a prostate problem. That's it. I'm going to need major surgery, or I'm going to have something lopped off, or need major, I'm going to lose function around sex or whatever else. Not the case at all. So the good news is that the vast majority of the time, if you are diagnosed with prostate cancer, it's not going to need immediate surgery or radiation. In fact, it's readily treated by a lot of different modalities, which brings us to the next slide. And I see in our audience here that this is a really smart group, and almost everyone in the audience got it right. So what are the treatments that are out there for it? Most importantly, especially for stage 1 and stage 2, and prostate cancer goes to stage 4. For the vast majority of early stage disease, which is stage 1 and 2, where it's really confined to just the prostate gland itself, it hasn't spread to local tissue. It's active surveillance, or the procedure itself. Often, when they do the biopsy, that's enough to track it. So at that point, you just go ahead and watch the patient carefully. You do PSAs. If you need it, you do some imaging if you need it, and you're done. And you just follow that patient. Going back to the analogy we talked about earlier, if it's not an aggressive form of prostate cancer, the patient's 90 years old, you're not going to do surgery, right? If the risks of the surgery are going to far exceed any benefits you're going to get to prostate health. Surgery is reserved in certain circumstances. If you're a young patient, it's a fast-growing tumor, you may want to do it. So if it's a healthy young patient, they don't have much surgical risk, and it's easily and readily cured, you're going to go for it. Even on a stage 3, if it's a little bit of spread, but you think you can get the cancer out completely without having to do anything else, there may be a role for surgery. Radiation therapy often is an alternative to surgery for stage 3. So it's now gotten outside the prostate gland, it's in local tissue around it. There may be a role for radiation therapy in that sense, especially if you're going to do hormone therapy with it. Hormone therapy, again, often stage 3. We talked about it in combination with radiation. It's usually the prostate has grown. The cancer is a little bit outside the prostate gland itself, but it hasn't spread. Chemotherapy is going to be reserved for advanced spread, right? It's gone to other parts of the body. You need a more systemic approach, and that's where you're going to combine with chemotherapy. So there is a very staged approach to it, balancing the age of the patient, where they are, how aggressive the treatment is, what their own goals are. You'll often hear drugs described for the hormone therapy. You'll hear about a lot about Lupron, is Zoladex, Trelstar are the common ones for chemotherapy. Taxotere and Jeptana are the common drugs you'll hear about if you hear from friends and family who are involved in any sorts of therapy. Thoughts on PSA is staying normal range, even in stage 1. Welcome back to that as well. I'm going to come back to the questions here. I want to make sure we get through it. So what do we do with support? So we talked earlier about, you know what, it's important to talk to your doctor. It's important to talk to your peer group. There is no stigma in going and speaking with friends, family, your clinician about this. We talked earlier, one of the big non-modifiable risk factor is age. If you get older, it's going to become an issue. And even in younger folks, not uncommon to have a little bit of blood in the urine, either from that bike ride, from sexual activity. Going to get it checked out, make sure it's probably nothing more than a prostatitis, but you want to make sure you talk to somebody about it. We talked about annual wellness exams, right? To screen, talk to your doctor about a PSA. So it's important to make sure you get that done. Healthy lifestyle. We talked about different dietary approaches you can take as well as you think about it. And community and workplace wellness programs. Again, even what we're doing right now, you're hopefully outside enjoying a beautiful walk and listening to this. Think about what else you can do, who else you can talk to, and take advantage of resources that are available. We talked about a real age before. If you have access to a real age calculator, figure out what your real age is, what tests are appropriate based on your calendar age, and even where you are in terms of your real age. You want to think about both those at the same time. Which brings us to, I believe, our last slide, talking about the prostate and your overall health. You know what? We saw in that first picture of the prostate gland, tiny little organ, tight little gland, but it can cause a lot of problems for you depending on where the plumbing runs through. So the good news is, we talked about earlier, you're going to have symptoms. Just because of where it's located, you're going to feel it. You're going to have urinary symptoms related to any problems with the prostate almost all the time. Not all the time, but almost all the time. The good news as well, that when you pick up a problem with your prostate, it's curable. We talked about benign prostatic hypertrophy, or BPH, being just a benign condition. Yes, it's a pain in the butt. You're getting up to pee every night, or you're having to pee more often. Readily, tons of treatments available to it. Prostatitis, there's blood in the urine. That's going to freak anybody out. But again, readily treated with appropriate care and antibiotics. even prostate cancer, we talked about, that's a good cancer to get if you're going to get a cancer, 95% cure rate overall. So the good news is that you don't want to blow off your prostate. It's prostate month. This is the month where you want to think about it. You want to make sure you address it. And don't just think about prostate, think about your overall health as well. Good chance to make sure your endocrine, your diabetic level or diabetes A1C is appropriate. Your blood pressure is appropriate. All the other health that we sometimes don't talk about when we're talking about prostate, you don't want to ignore. Make sure you're up on all your screenings that are appropriate for our age. And again, I think the other takeaway from this is the PSA, which we hear the most about, is something you want to have a thoughtful discussion with your clinician about before you go off being rightful about it. And with that, do your homework, empower yourself, know your own prostate gland, and I'll turn it over to Katie for any follow-up.
Awesome. What a wonderful presentation. Love the engagement. I'm just double checking to see if there's any questions we didn't get to. Did we talk about a carnivore diet? Has it been shown to increase the risk of prostate cancer? I know we talked about obesity and nutrition.
It's a debatable topic. I would be out on a limb if I said the carnivore diet would be increasing your risk of prostate cancer. In fact, I think I turn it upside down and say we know that certain diets that are high in fiber, high fruits, veggies, legumes, they seem to have a lower risk of prostate cancer, but that doesn't mean the converse is true. So I'd be remiss if I said carnivore diet is going to increase your risk of prostate cancer. I just don't think we know. Not enough good data out there. It's hard to get good data on this type of topic. Good
Yep.
question.
Absolutely. And I think we got to almost all the other questions.
That's good. Well, if you have more, please put them in the chat or reach out directly. We want to make sure you get your questions answered, and super grateful for your time on September or Prostate Month.
Yes, thank you so much. So we're wrapping up prostate health. The journey of a healthier you continues in 2025 as we approach October and November, and we learn about breast cancer and diabetes awareness and prevention. So we're looking forward to those topics coming up. And as always, want to talk about Care First well-being and how we can support you all with our Care First resources. So Care First Wellbeing is your go-to solution for everything health and wellness. It is your personalized digital connection to your well-being. If you have access to Care First Wellbeing, you know you can take your real age health assessment. Thank you so many times for pointing that out, Dr. Odwin. It's one of the, if not the most important thing you can do within Care First Wellbeing is to understand your real age based on health years versus the calendar years. I like to tell people I'm still in my 20s per my real age. Don't look at my license. Within Care First Wellbeing, you also have a personalized health timeline feed, articles, quizzes, insights, more, tracking capabilities to sync your wearable devices or enter your own data, ongoing engaging challenges that change and rotate every month, a personalized health profile to help you keep all that important health data in one place, as well as some of our core programs. Those programs include health coaching, 2 different weight management and diabetes prevention programs, smoking cessation, financial well-being, and a discount program called Blue 365. Going into health coaching at a very high level, I know we're running out of time. Care First offers a lifestyle management and a disease management. These are telephonic programs. Both are telephonic, and with both you get a dedicated health coach. In lifestyle management, anyone is eligible. You will have a certified health educator or health coach that will help you on lifestyle behaviors such as increasing physical activity, eating better, lowering stress. You'll work together to create SMART goals and achieve a healthier you. Condition management or disease management, you do need to qualify by having one of our 10 core chronic conditions. And in this pathway, you will work with a registered nurse and dive a little bit deeper into your clinical condition as far as medication management, your provider recommendations, your numbers, etc. And then we have close-knit. So Dr. Unwin so beautifully said, what better time than right now to focus on your health? Especially if you're a man and you've learned all about prostate health. Close-knit is centralized and connected care that is virtual first. So it's a great first step to take in your overall health and well-being. You can access close-knit 24/7. You can have your primary care services through close-knit, as well as your urgent care, behavioral and mental health, and more. Highly recommend you look into close-knit to get connected to care. And as always, we just try to provide as much resources and tools as we can to our families, members, communities, you name it. Here we've listed Care First resources, Find a Doctor, preventative care checklist, our very robust and educational health library, as well as our care management programs available to you. Awesome. And just want to thank Dr. Udwin so very much for this amazing presentation. I've heard it several times now, and I just still find it just as fascinating. So love the partnership. Thank you for your time. We appreciate you. And we appreciate everyone for joining. Thank you for attending our Wellness Wednesday webinar. We hope you have a happy and healthy day, and we'll see you next month.